of screening, whether in terms of quality of referrals. I think, this is area which we are talking about across the board, whether it is RBSK program or it is a nutrition program or it is a newborn health program. I think quality is across is a challenge, and we have to keep on identifying those issues, and also we have to keep on finding state specific solution as well, because we as a government of India are here to support you both in terms of the financial support which is provided under the National Health Mission program, and then we also have the technical support also available which can be provided. Now we have with us a co-chair with us for a RBSK program, and I think you must be knowing Dr. Arun Singh. He is the person who is working around RBSK program, and he has an in-depth knowledge of the RBSK program. And we also have the co-chair as Dr. Vinod Paul. I think you all must be knowing Dr. Vinod Paul. He was supposed to be there on the day one, but somehow he couldn't come. But thank you very much, Dr. Paul, for being with us. And he is the head of the Department of Pediatrics at All India Institute of Medical Sciences. And he has a large experience in managing the child health program. It is not that he is in a hospital. I think he is 80% of the mind is in the community, and he knows the ins and outs of the program. Maybe I'll request Dr. Arun Singh first to just give us some kind of a message to the child health nodal officers in terms of the what are the they must do kind of a thing in terms of improving the RBSK program, and then I'll request Dr. Vinod Pal to tell us something 5 key messages which our child health program manager must do to improve the child survival in the country. Dr. Arun.
Thank you very much. Few important things. I think what comes is, I would put my observation in 3 different aspects. One is screening. Now, we made a very important statement in RBSK. Screening should be done by generalist and management by specialist, so that the management quality can improve, and those who are managing it should not divide their time into screening mainly. Now, but one question I would say, please request the teams. One of the common mistakes which I call an OPD practice is to start from asking, what is your problem? The moment you ask what is your problem, screening is over. That means you are relying on the mother's perception of the problem, which may or may not be correct, which may be divided into what she thinks as an acute problem. So you are going to miss out on a lot. So I think the first thing, how to stop this? Government of India has given you a form. Lot of states don't follow it. They have made it short. They have made it. I know if you follow that form, so even if a child comes with, the mother says that the child has some eye problem, but if you follow the form, you have to identify every problem, every system, the 4 Ds, and then qualify. If you allow this, then the screening quality will improve. But if you only depend on asking the mother or the father what is the problem, or the guardian, we miss it. So this is number 1 as far as screening is considered. Number 2, and if you assure this, the timing of screening, the quality itself will improve. If in a particular area you are finding that especially the developmental delay, people miss it out. If that is not being asked, please give them the proper training and assure. Very soon we'll come up with an apps also which can be put in your laptop, which has been supplied to each team, so that they can help in very quick assessment. Second thing is referral. Now in referral, we are not asking a regimental referral. That means you refer it to PHCDS. Depending upon the condition, the state officers must map, if this is the problem, where they should go. What happens now in the system is, you refer to your next center, the next center refers to the next center, and each referral costs time and energy to the parents. So it would be proper to tell them where exactly to go, and that can be produced like a booklet that for this problem, this is where they need to go. If that can be shared, then unnecessary loading a system and each system trying to say, I don't have people. In this regard, some good practice done by states is that they have fixed a day. So on that particular day, in the whole state, any referral of child goes. You can also do that. There could be emergency situation, every day is referral, but in this. And it would be good that if the team accompanies where they are referred. The last is the tertiary management, where a lot of surgical managements are also there. I think you have to improve the capacity over a course of time in the state, especially in the government institutions, to manage these cases. My last line is, you have to educate everybody who manages, because management is done at a silo level. I have referred for congenital heart disease, I have referred for eye. There is a one important message: child is in the center and cognition of the child is the center to it. So I think if this message is not there, lot of referrals do not actually carry the meaning which it should be. I'll give you a small example. You have discovered a cataract in a newborn. You have referred it to an eye surgeon. The eye surgeon has said, let me see other problems in the child. Very good. Then he gives a message, well, you can get the child operated within next 2 years. Somebody has to tell, each day which you miss out, it is not the eye only which is suffering, it is the cognition which is suffering. Eye is window to the brain. And this applies for all the treatments, especially in young children which you do. So I would say you have to educate the system that there is an interlink and that each day is causing a loss of cognition. That has to be there. Lastly, the DIC is a huge challenge, but I think if we start taking steps, it will be possible. And DICs are an essential component of SNCUs, because SNCUs are improving the survival, but the quality of survival can only be improved if you join hands with DIC, and the DIC team must visit the SNCU. My last thing is that please understand RBSK has various components. So the first component is we expect at all delivery points somebody to see the child is okay or not. At all SNCUs that the follow-up is with the DIC or not. Second component is by the ASHA to see if she sees. The third component is by the mobile health team. And the fourth component is a passive reporting wherever people are accessing services for any of the conditions. So I stop here if there is any clarity, but I think this is, I have one request to you, sir, the chair, that you just heard the perspective from the Deloitte team of the logistics and how it is being implemented. So there is another study which talks about, which talks about the people's perspective, which was done by Deloitte and UNICEF. Sir, if you permit so.
No, I'm just calling.
Okay.
I just got it. So thank you very much, Dr. Arun Singh, for comprehending the 5-6 critical messages. Because I remember when we started the program, our emphasis was only mobile team. And we thought that mobile team is the only element. But if you look into a holistic approach to the RBSK program, I think there is a lot more to be done at the delivery point. And we have been able to, bring out some dedicated guidelines, how to screen children in terms of finding out birth defects at all delivery points. And then the second point, which also we missed in our operation guideline, is the linkages between SNCU and the DIC. Because initially when we started the program, we were busy in establishing the program in terms of bringing RBSK dedicated mobile teams at the block level. But now, we are quite comfortable with the teams which are in place. I told you more than 10,000 teams at different blocks. I think it's a huge number, around more than 40,000 people dedicated for the RBSK program. But I think one of the missing element, because at this point of time, the purpose of calling all the nodal officers, whether they belong to newborn health, whether they belong to child health stream, whether they belong to nutrition stream, or they belong to ASHA stream as a manager, I think that's why we invited all the 4 program managers at one point of time, so that they can develop some kind of a networking. At least SNSU and the DIC, I think it's high time that we need to link them. And we are quite happy to note that more than 8 lakh newborns are getting admitted in our SNSUs. And our SNSU system is now quite mature in terms of online reporting, in terms of quality of care. There's always a scope of improvement, but things have matured to a large extent. But we cannot, just be happy with the survival. As Dr. Arun mentioned, that we have to think of equality. It's not thinking, there is a system available. We have to make use of the system. So linking, DICs and the SNSU will be a very, very, positive step in that direction. So we stop here, but another, assessment which Dr. Arun Singh just mentioned, we have a team, again from the Deloitte, we requested Deloitte to give us, some kind of insight about, the public perception about RBSK program. And the purpose of this, public perception was because, we wanted to create some kind of a demand in the community, demand generation. And somehow, RBSK program, to my understanding, even the health system is not aware. Health system is the existing health system of sub-center, PHC, district machinery. Nobody is aware. RBSK is a separate vertical program. So, there is a high time that we might have to do advocacy with the health system. We might have to do advocacy with the other, social system, maybe the Ministry of Social Justice, maybe the school people, because, people sometimes call, somebody made a mention, that some people presume RBSK is nothing but a name change of the school health program. But that is not the true fact. School health is a very, very small element of the whole RBSK program. The concept, the approach is entirely different than school health. That's why we say school health program gets subsumed under the RBSK program. But, somehow this message is not clear across the board. So we did a kind of, thorough assessment so that, we can develop a so-called evidence-based demand generation material. Instead of, just creating some material on RBSK, we thought let's do some kind of a scientific study, and you all must be aware that communication is a science in itself. It's a big science where you have to follow the principles of communication. They develop something, they understand the people, talk to the people, do pre-testing. So I'm very happy to note that, we have a very learned person, we have, Dr. Praveen and Dr. Geeta Sharma from UNICEF, who will present their, kind of a insight about this cap on demand side. Dr. Praveen.
Respected Chair, Co-Chair, dignitaries on the dais and dignitaries off the dais. In fact, this is a study. But this is a study which was requested by the ministry and which UNICEF took over, and actually it was done on the field by Deloitte. This study, in fact, it will have been apt if the RBSK team leader would have been presenting this, because it was actually led by him. But because he's sitting on the dais, we are presenting this. This is a formative study to understand the perceptions of parents and communities regarding RBSK, as well as the motivations, triggers for seeking early screening and intervention. As you know, the RBSK has 4 Ds, but this study was in fact conducted only for the initial 2 Ds, which is birth defects and developmental delays, because these are the ones which are obvious to the families and to the communities at a much early stage. In fact, As you know, as I had mentioned, it's an entire team which had from ministry, from UNICEF, and from Deloitte, which has been part of this study. The rationale for the study was that very little is known about attitudes and perceptions surrounding these two Ds, which are birth defects and developmental delays. So a formative study was conducted to inform the development of a communication framework. In fact, earlier, the ministry and UNICEF, we had actually developed this RBSK branding. We had developed certain communication materials, but then for a larger venturing into this communication side, we thought that a study is required. It was conducted in 8 hard priority districts of 5 states, and these states are UP, Meghalaya, Tripura, Maharashtra, and Karnataka. The selection criteria was that there is a presence of mobile health teams. The social, educational, health, and economic indicators are, we had taken it into consideration, and also on the geographical spread of the districts. The total sample size covered for the in-depth interviews and for the FGDs was around 1,137. And it covered a range right from the village level to the block, to the district, to the state, and to the national offices. There was interviews, there were FGDs right at the village level, at the block level. Now the key findings from the demand side are that the study represented was with a diverse set of birth defects and development delays across the state. 25% of those which we had interviewed had, the families had someone who had a congenital heart disease, and in the developmental delays, almost a proportion of them, of around 27%, has some language delay. The 55% of respondents are aware of RBSK, although having some limited knowledge. This was one of the study findings. And the source of information was Anganwadi workers was the greatest one, and after that was the ASHA, and then the school teacher. Most respondents did not know the rationale to the program and did not understand the importance of early interventions though. Most caregivers were unaware of any technical or medical details of their child's condition, and very few were able to explain the condition in medical terms. About 40% of the caregivers of children with birth defects were aware of the conditions since birth, and since development delays take some time to manifest, only 15% of the caregivers of children with developmental delays were aware of the condition since birth. Now, during this study, we had woven a story, which was a fictitious Kamla, who was around 33 years old, and who lived with her husband and had 4 children, and one of them had some hearing impairment, and had both the issues of speech and hearing. And based on this fictitious one, we had then interviewed the families with conditions, with children with some conditions, whether they are being socially excluded. 98% of them agreed, and whether they are being mocked by other children, 69% agreed, and whether these children with special needs are being given less importance by the school teachers. 52% of the respondents said yes, they disagreed. And having a male child with some problem is better or easier than a female child, 62% of them agreed. And parents of these children will use a program like RBSK if they are aware of it. 96% of them agreed. So I think the acceptance to this program, if at all this is well run, then there is a large acceptance. Over 50% of the caregivers were plagued with feelings of worry or depression when they found out about their child's condition. Nearly 32% of the respondents felt that the community members encouraged them to seek medical care, and 24% of the parents of caregivers of children with 2Ds shared that the community members were sympathetic towards them. More than 40% of the respondents felt that Ashas and Anganwadi workers were only playing a role in provision of information and offering some verbal solace, but then they actually didn't have an actual solution. They were only giving some solace to them. From here onwards, I'll request Geeta, my colleague, to take over.
Thank you, Dr. Praveen. Thank you, sir, for the opportunity. I'll just quickly take you through the findings, because what we found in the field, and just like Dr. Kheda said, it's very important for us to translate this data into how are we going to package our information, what we are going to do, and very importantly, what we are not going to do, so that the families for whom it is meant are able to have an uptake of the program. So most of the respondents who associated a range of beliefs with their children, we were quite surprised to find that not a majority of them felt that it was only due to God's willingness, because when we went into it, we thought that they would have that fatalistic attitude. And some said that they did not have any particular belief. Some felt that they had some poor health-seeking habits because of which it had happened. And this will have very important implications for us to design our behavior change communication strategy. In terms of the private health facilities which are preferred for the treatment of the children with the 2Ds, 35% of the parents, now this is important because we are looking at 35% of the parents who sought treatment at the private sector and had incurred an average out-of-pocket expense of 45,000. And here you have an RBSK program which is trying its best to offer everything free. So how do we do that matchmaking where there is a government and a system which is providing the service free, and then you have the private sector and the caregivers are going there and having such a huge out-of-pocket expense. Then of course, there are the figures in front of you. 16% of the parents sought treatment at a government hospital. 32% of the respondents who also reported visiting a local PHC or a CHC as a first level of health checkup and care. And that to us from a communication perspective or from a program uptake perspective is that if we have to capture these 32% and not let them go away, so we have to direct them, like Dr. Arun Singh was saying, we have to build the referral change and not let them go away. Then there were also about 30% of the respondents who felt that the decision making was jointly done by the parents together. Again, when we do our messaging, we are not just going to focus on the father or the mother, because both have to be our target audience in terms of how we pitch the emotional message on why they should seek care for their children and timely care. Finance and transport are two major barriers, and later we'll see when we look at the communication framework that these are also enablers. So what are the reasons that almost 52% of 52% of the caregivers identified finance as their major barriers? We saw at 45,000 with some caregivers, and some were almost spending 9,50,000. 20% of the